Hello, everyone. Thank you for joining today. And it's an honor for me to introduce Dr. Salim Yusuf to the audience today, which of course needs no introduction. However, I will provide two impressive statistics about Dr. Yusuf. The first one is about during his career, he accumulated more than 300,000 citations, and his H citation index is over 200. And according to modern search engines, he is in the top 10 of the highest cited scientists of all time. And in that top 10, there are not even a single Nobel Prize laureate. So I think that Dr. Yusuf deserves to be called one of the most influential scientists of modern medicine. And then the second statistic is about the institution he represents. He's founder, president, and vision of the Population Health Research Institute, a global leader in clinical research. PHRI publishes more than 500 papers per year. That means 1 or 2 papers per day, including weekends. And 1 or 2 per week go to major journals like New England, JAMA, BMJ, Lancet, etc. So it's out of question also that PHRI, the institution that Dr. Yusuf leads, is a clear global leader in clinical research. So, and personally speaking, Dr. Yusuf is the busiest person I ever met. So thank you, Dr. Yusuf, for joining today.
Well, thank you, Pablo, for this very warm introduction. I don't think I'm the busiest people. I've met others who are much more busy, but I'm not unbusy. Excuse me. So it's good to be speaking through this medium with all our colleagues in Argentina. And, I would love to come and say hello to you all in person, but circumstances don't permit it. So happy to do this instead. So go ahead, Pablo.
Okay, thank you, Dr. Yusuf. So our meeting this year has a motto, which is challenging the present and constructing the future. Challenging the present is something you have been doing for decades, to be honest. And then, especially during the last decade, you challenged core knowledge or core principles of nutrition recommendations like low sodium diets, low fat diets. And what do you think we are going now? How your research shaped, public opinion, clinical guidelines? What is the future about this?
Well, that's a very big question. I think most of my research relates to trying to find new treatments and prevention strategies. So as you know, I was involved with beta blockers in acute MI, then with the thrombolytics and aspirin story in ISIS-2, ACE inhibitors on SALT and HOPE, then dual antiplatelet therapy in the CURE study, and new antithrombotics like fondaparinux. Then in atrial fibrillation, we were involved with studies of the NOACs showing dabigatran was superior to warfarin, and then more recently the COMPASS study showing rivaroxaban along with aspirin was superior to aspirin alone or rivaroxaban alone. So most of my treatment's been around that. We did the HOPE study with ACE inhibitors. As I told you, we followed up with various studies such as in the HOPE-3, where we showed statins plus blood pressure lowering primary prevention was helpful. But one of the most important studies was the HOPE-4 study, where we actually took everything we knew and had an implementation strategy. And that was done in Colombia and in Malaysia in 30 communities. And we randomized the communities to an active intervention arm and a control arm. So it's a strategy. And in the active arm, we had non-physician health workers being the core person facilitating prevention. And we were able to control hypertension in 85% of the people, compared to about 40% in the usual care, and also reduce the Framingham risk score by 50%, which in theory should translate to a 50% reduction in cardiovascular disease. So I think we now have the tools to reduce cardiovascular disease at low cost in the community by half. And that's big, given that cardiovascular disease is the commonest disease burden in the world. So I've been involved in a number of things. You asked me about diet. we set up the pure study because most of the data we had was from rich country. This is the epidemiological data was from rich countries. And we did not know whether that would apply to countries outside Western countries, middle-income countries, low-income countries. We didn't know whether it would apply to rural areas. We didn't know it will apply to different continents, South America, Asia, Africa, Middle East, and others. So we set up the pure study in 27 countries. It now has 200,000 people from over 1,000 communities. And one of the core things and the goal of that was to understand the determinants of health. And we were interested in the community determinants of health and social determinants, but we were also interested in behavioral aspects. And diet was one of the most important ones we studied. It took a lot of effort. And over the years, we've now published about 30 papers on diet. And essentially, we've shown that the story on fats need to be rethought. The evidence that low fats are associated with a lower risk of cardiovascular disease has always been weak, and it was exaggerated by selective emphasis on certain papers. And what we showed was that all fats in moderate amounts are protective, including saturated fats. And what we showed, though, was carbohydrates were the real culprit, high carbohydrate diet. Now, again, moderate carbohydrate diets are fine. High carbohydrate diets, especially those with refined grains and with high glycemic index, were the ones that were increased the risk of mortality and CVD. So that was one. The other one we showed is things that often people said you shouldn't consume, like dairy. Whole fat dairy was actually protected. And obviously we found fruits and vegetables were helpful, but we also found that if you ate cooked vegetables, it was less protective than raw vegetables, and that's important. Nuts, much to our surprise, seem to be protective, although I must say, I was a skeptic of the nut story, but I thought it was really nutty, but it seemed to be protective in our data. Now, these are all observational studies, and good randomized trials simply don't exist. In fact, the few randomized trials that have been done, most of them on diet have been neutral, and some even harmful. In fact, the ones that have been harmful are the ones you tried to reduce fats, and some of them were suppressed for many years and then came out later. The Predimed study is an interesting study, and although it's meant to be a randomized trial, it really wasn't a randomized trial. Nevertheless, the results are impressive, and I think it should be taken seriously. So we worked on the diet part. Salt is another area. There is no doubt that sodium is related to blood pressure, but but the relationship is not one-to-one. And we found that versus cardiovascular events, it's a U-shaped curve, that there is a sweet spot in the middle in the range of 3 to 5 grams of sodium per day. And over 5, you have an increased mortality and increased stroke and cardiovascular disease. And below 3, you have an increase in cardiovascular disease as well. And the reason for that is at the low end, when you lower sodium too much, the renin-angiotensin system is activated. Lots and lots of studies have shown that. And we know that activation of the renin-angiotensin system is not good. So these suggest that with diet, it's an issue of moderation, not extreme. So I would have moderate salt. I've had moderate amounts of small amount of meat, and fish doesn't hurt you. Small amount of fats, butter doesn't hurt you, and dairy, especially whole fat dairy, is good for you. Cheeses in whole fat, but not a lot, but moderate amounts. So the story in diet should be consuming a varied diet, but the one that is in moderation, avoiding ultra processed foods, and avoiding refined carbohydrates. That's what I would say is where the story is now.
So that's a great insight. And I remember that in terms of about all this confusion about the trials and the observational studies. I remember Andrew Mente showing one of his slides, the appendix of one of these trials of low fat versus high fat or Mediterranean diet, basically, and showing that the active treatment arm, which is the Mediterranean diet, had higher saturated fat consumption. So, I mean, there's a lot of ambiguity, in micronutrients, macronutrients, and the whole food. So, what do you think about that?
I think we should focus on foods as opposed to macronutrients, because first, macronutrients don't exist in isolation. And second is, we don't go to a grocery store and say, give me 30 grams of saturated fats and 50 grams of poly or so much of carbohydrate. We buy meats, fish, vegetables, various bread, rice, wheat. So we should focus on foods and come up with recommendations based on food rather than nutrients. The nutrients are useful in trying to understand things, but quite honestly, it's quite complex. The second thing is, I'm a believer in a variety in the diet. Variety is important. And I'm a believer in moderation. You don't eat too much of anything. So our data shows consuming 4 servings of fruits and vegetables a day is pretty good, and going to 5, 6, 7, 8 doesn't add anything. So if you want to eat it, you can eat it, but don't eat it thinking that it's going to give you special benefit. Similarly, on meats, you can have a small amount of meat. Obviously, don't eat a cow at every meal like we do in Argentina, but small amounts are fine. Incidentally, eggs are neutral as well. So one egg a day is fine, or even 2 eggs a day is fine. But anything more than that, we don't have good data. So moderation is my story.
Yeah, and that's a key message for sure. And now, like beyond nutrition, in which other area of cardiovascular disease you think that we need to challenge now? We need to change the present. Which of them you think comes to your mind that should be challenged?
Well, there are obviously management of certain conditions that we need to improve the treatments, and the one that always comes to mind is the overuse of PCI in stable coronary disease. I think it's probably good for symptoms, but not for prognosis in stable coronary disease. I'm not talking about unstable coronary disease. And it could be that we based on the recent data from so many studies, it's time to reduce the amounts of elective PCI in stable coronary disease, and to perhaps increase in unstable disease. So that's one. The other area to think about is simple things like oxygen in the CCU. No good data for that. But the new areas to focus on are air pollution, the environment, the climate change, what their effects are. They will have significant effects. And other areas to work on is new biomarkers that are powerful, not slight increments, but are really powerful, such as ACE2. Now, the thing, though, is we need to, at the same time, use modern day techniques to find out, are these causally related or just bystander? And so for that, things like the concept of Mendelian randomization will help us clarify it. So there is a lot of new things happening, and a lot more to learn. So and obesity is again an area where, I think the current standards for obesity, that anything over 30 is abnormal, needs to be rethought, especially if you have vascular disease, because it may be in these people you do need the fat to protect you, and 25 being the cutoff for normal is probably not appropriate. Maybe higher, 27 or 30. And it's been focused basically on risk factors like diabetes or blood pressure, and that may be true. But in reality, if you look at hard clinical endpoints, there's no difference. in between 25 and 30 and below 25 in terms of events in BMI. So that's another one to be challenged.
Actually, remember that maybe the conclusion from my thesis was something like that, right? Maybe we don't have a clear-cut idea, what is normal, abnormal. Maybe the setting may change. I mean, people are higher. We show that at higher risk of death, the optimal BMI is higher, which makes sense, right? So I think that is, of course, needs to be changed. Actually, indeed, there was a TIMI trial published like 1 or 2 years ago, that achieved a significant weight reduction over several years and no impact in benefits. So, I mean, we have look-ahead trial early stopped, after 10 years, for futility. So, I mean, we need to, that is, of course, another area that should be challenged. And now moving to the other part of the motto about constructing the future. Mm-hmm. So in 1984, like 36 years ago, like a few months before I was even born, you published one of your most popular papers, why do we need some large, simple clinical randomized trials? And since that moment is the standard way to generate high quality research that in many times is translated into clinical practice changes. So do you think that is going to change, or is already changing maybe in some way and we are not noticing it, or if so, when is it going to happen?
Well, the large simple trial concept did make an impact because of the success of the ISIS trials. And say trials like the SOLVE trial and the DIGE trial were large long-term trials that were simple. The concept of large numbers is now being fully accepted. But what is not fully appreciated is that simplicity is a virtue. People feel simplicity is an excuse, but it's a virtue. And that's something that we need to incorporate, because that will allow us to do many trials of potentially useful therapies. The other thing that we may have to do is we generally do trials with one question at a time, but it may be better to think of factorial designs and test more than one question at a time. In the end, clinical events are what matters most, but embedding studies with some mechanistic insights will also be useful. So clinical trials have made a huge step forward in the last 25, 30 years, and I think we'll continue to do so.
Okay, and that said, what about funding allocation? I mean, as you know, it's very important how we allocate resources.
Right.
I grossly speaking, in my mind, is like there are three ways to invest in, for grants. I mean, you have like basic science, new drugs, breakthrough discoveries. Then another area is like use an old drug for a new indication. For instance, colchicine in coronary artery disease is a clear example. And then the third one is like Hope for trial, like you mentioned, and I'm very familiar with that. All things that we already know that works using evidence-based medicine, how to better apply to make sure that people take the blood-lowering medication, blood pressure-lowering medication, or the lipid-lowering medication. So do you think those three areas are equally important? We should invest one in...
I think they're all are equally important. I mean, how important they are relative to each other depends on the state of knowledge in an area. If you don't have the scientific discoveries that says one or two treatments work, you can't do knowledge translation, and you need much more basic research. But as we discover new molecules or new approaches to prevention using basic research, it would be a tragedy not to try them out in populations. And if they work, that should have big impact on the health of lots and lots of people.
Yeah. So therefore, Dr. Yusuf, in the name of the audience, we're very thankful for this interview and sharing your time and your thoughts about how all this is shaping the future. So, and personally, always very grateful for all the things you have done for me. So, thank you, Dr. Yusuf, for this meeting.
Pablo, you and your colleagues and friends in Argentina, stay safe. Thank you.
Thank you, Dr. Yusuf.